Welcome back to the Pastore podcast. Today we are continuing on the topic of celiac disease, and Dr. Pastore is going to introduce two new symptoms of either a person being undiagnosed with celiac disease, and this may be their only sign that they do have celiac disease, or for those that are diagnosed as celiac, it could be a sign that you have ingested gluten and you're not sure or you're not aware of it. So Dr. Pastore, before we get into the new symptoms of celiac disease, can you just give us a refresher on the classic symptoms?
Yes. So the classic symptoms, I believe every gastroenterologist and internist is hopefully familiar with those. And those are abdominal pain, particularly after you eat, bloating also, particularly after you eat something. There's a skin condition we covered on a whole separate podcast that I invite our listeners to please tune into that one if you didn't already, and it's known as dermatitis herpetiformis. Then there's a diarrhea, which is just a classic gastrointestinal symptom. There could be some swelling, which is known as edema, that can transpire. That's unknown. It's not associated with another disease. People can be extremely lethargic or experience profound fatigue. That can be tied to the next thing, which is actually iron deficiency anemia. You can have really intense gas pain. Again, also postprandial, which means after eating. You can have an itchy rash that is not dermatitis herpetiformis. You can have something known as steatorrhea, which is a different type of diarrhea where your bowel movements are floating and they're almost like oil slicks. And that's a classic sign of malabsorption of fat and fat-soluble vitamins and important fat nutrients. Then there could be weight loss that's unexplained. And those are the classic, right out of the medical textbook, AMA definition for, American Medical Association, definition for classic celiac disease.
And in the past, we have covered a handful of podcasts on the non-classic symptoms of celiac disease. And we've talked about how you call celiac disease a clinical chameleon because it is so tough to diagnose because most of the time those classic symptoms aren't the most common. So what else do people have to look out for as symptoms of celiac disease?
This is a long list, and thanks for bringing that up because it's really been my bread and butter. So that's funny there, bread and butter. So
I can have.
Yeah, so I can't even eat either one of those things. This really was the basis of my work, was trying to make these more known and make these more common. But right now they're called non-classic symptoms or uncommon symptoms. They include alopecia, which is a form of hair loss. The cessation of periods in women, which is known as amenorrhea. You can have something, again, we talked about this a lot on podcasts, aphthous stomatitis, or what we call canker sores. You can have a form of a balance issue known as ataxia. You can have cognitive impairment. You can have constipation, which is the exact opposite of what one would expect with celiac disease, probably the most ignored symptom, believe it or not. For young women, there's a sad history of delayed onset of puberty, known as delayed menarche. There's dental defects. We did a whole podcast on that. We did pretty good. Enamel defects is what it's called, dental enamel defects. There's depression, dyspepsia, which is inability to properly perform the function of creating enough hydrochloric acid and unfolding proteins in your stomach, which can give you this almost reflux-like experience, but it's separate from it. It's known as dyspepsia. There's fertility problems, whole podcast on that. For men and women, there's headaches, heartburn, there's irritability, there's elevations in liver enzymes. That's another one that really vexes a lot of doctors. There's deficiencies, and we covered a whole host of nutritional deficiencies, B12, folate, zinc, essential fatty acids, vitamin D, vitamin E, vitamin K, vitamin A. Really important to make sure if you have celiac disease that you're examined for these. There can be obesity. I wrote a whole article on that.
And we did a whole podcast.
Yeah, and that was Joseph Murray, God bless him, one of my heroes in academics, and I published with Joseph. Dr. Murray was the first person to put that on my radar back in 1999 when he was still in Ireland. He published this amazing paper that you could be overweight, and his first case in the United States, in the central United States, he was blown away by the first patient he saw that had celiac disease was a woman that was quite obese and suffered from all these secondary diseases, and all the doctors said, she has a disease of abundance, right? Real horrible medicine. One could even dare say sexist, but definitely not nice way to go about diagnosing an individual. And Dr. Murray is such a great sleuth as a physician, and he identified that she had full-blown flattened, destroyed villi, microvilli. She was hyper-absorbing carbohydrates in other areas of the intestine that were not really meant for that purpose because the body adapts. We did a whole podcast on that. So that's another very important symptom. Osteoporosis, osteopenia, any type of bone loss, peripheral neuropathy, which is a numbness or tingling of your hands or feet, pancreatitis, inflammation of the pancreas, problems with pancreatic enzyme production, pulmonary disorders, breathing disorders, seizure disorders, thyroid disorders, chronic urinary stone disease. That's one that I actually caught while I was doing clinical research in a colleague. That was pretty awesome. So then I found all the clinical studies to prove my point and added it into my personal work on celiac disease. One of my favorites, and this is my language for a non-classic symptom, refractory vitamin D deficiency. So I've seen a lot of patients where they come in with like a vitamin D of 9. And for our listening audience, if you're in the States, we measure by nanograms per deciliter. And if you have less than 30, you're considered clinically deficient. And there's a group
9 is really low.
9 is really deficient, but there's even making it worse. There's some brilliant physicians out there that, like Michael Hollick, if you're not familiar with him, definitely look into Dr. Michael Hollick from Brown. But Michael is probably one of the best lecturers and researchers on vitamin D. And he loves patients around 40. And wants to have the range moved up. So can you imagine if you're 9? Anyway, so what do doctors do? They give patients a massive dose. We're talking like 50,000 international units. And you'd expect even in a disease state that some would be absorbed. And I've seen cases of 9 patients on 100,000 IUs, and then they go to 8. So that's like, wow, wow, you have zero ability to absorb anything, and you went backwards. So that's refractory vitamin D deficiency. And then, of course, I talked about obesity, but then just an ununderstood, non-understanding, no medical reason that's known for just full-on weight gain slowly creeping up. And you're like, wait a minute, I'm doing everything right. Maybe I'm seeing a specialist. I've actually had a patient that was working with a great trainer. I literally had the exact calories they should be consuming. All the math was dialed in, and they were slowly gaining weight. And sure enough, it was celiac disease. There's a ton of that in the literature, which is how it made this list. And this list has been endorsed by Dr. Joseph Murray and some other great researchers.
And one thing to note here is that it could be one of any of the symptoms that Dr. Pastore just mentioned. You could have iron deficiency anemia, and your doctor's just like, okay, we're going to give you an iron supplement, the end. And it could be celiac disease, which is affecting your future health because it's going undiagnosed. You're continuing to consume gluten. So really, really pay attention to these symptoms. Make note if you have any of them and ask your doctor to be tested. We did a whole podcast on how to be tested. There's an article. I will link it in the show notes if you want to learn more about that.
Please.
So why is it that the body is reacting to gluten with celiac disease, and what is it doing?
Yeah, this is a really interesting, and that's a great point because it segues to this topic today. What we have to understand is that it's the immune system reaction in celiac disease patients that make gluten toxic. So that's a very important statement. And it's kind of like the chicken or the egg scenario in conversation, right? It's like obviously gluten in and of itself for a large portion of the population has helped people thrive and grow and reproduce and have a normal life. And forget about the whole arguments of where people stand on evolutionary nutrition. I'm published on that. So I'm just going to leave my flag in the 2015 sand of my publication of where I stand. But for all intents and purposes, it's the immune system reaction in the celiac disease patient that creates this toxic, and that's the actual definition, this toxic reaction to gluten. It is the driving basis of celiac disease. It's an autoimmune disease. And while that system is complex, I sat down and I really started giving this some thought because I was trying to explain this to a young patient recently. And I said, what's the best way I could explain it? And it actually started like this. I said, okay, you want me to keep simplifying this. So I'm sitting there and I'm huffing and puffing. And I said, okay, it's all about the T cells and their reaction to gluten. So while I have written about in an academic forum and published the full cascading immune system response that's pretty enormous and takes up 2 typed pages of single space of how this happens At the end of the day, there is a specific type of T cell known as a CD4 T cell. And that cell is geared in the celiac disease patient that carries the genes to specifically go at war with the what's called deaminated peptides that are found in gluten, the fragments of the unfolded gluten proteins in English. And in a very unique fashion, this is tied to what's known as human leukocytic antigen DQ allotypes in English, the genetics of HLA DQ2.5 and DQ8. We talked about this on our diagnosis podcast. We talked about this multiple times, that there are genes for celiac disease, and we could summarize them as 2 specific genes. Even though there's subtypes, let's keep the conversation really simple. So in English, you have the disease, you have the genes because you have the disease, you have specific T cells inside your body that are, oh my goodness, all out war is called upon gluten. And that is what initiates this whole list of symptoms that I discussed. And Lexi's so correct. It can be just one. And that is the basis of my work, hunting for that just one.
And today we're going to get into new acute symptoms of celiac disease. So before we get into that, can you just define what acute means in the medical space?
Yeah, this is wild. So in medicine and diagnostics, there's something known as acute and chronic. Chronic means you show up to your doctor's appointment and you go, my shoulders bother me when I do this, doc. And your doc says, how long is this going on? And you go, 2 years. That's a chronic shoulder problem, he writes in his notes. Let's try to figure out how to get a diagnosis. If you come in and say, I have this acute bout of vision loss in one eye that's going on for the last hour to 6 hours, that's an immediate acute symptom. That is a new symptom that you're experiencing, and we need to try to troubleshoot and get to the bottom of this. So that was kind of wild, that there's actually some new acute symptoms. They were there, and I kind of covered them in my work, and I purposefully left them out of my conversation in the opening to not give away the farm here of this podcast. But the way they present are absolutely new, and were even new to me.
And how did this come about? Where were these new symptoms discovered and researched enough to say definitely yes, in scientific research we can publish that these are new symptoms of celiac disease?
That is a dynamite question, because the answer is absolutely going to floor people that are current celiac disease patients themselves, or have a loved one that has celiac disease, or like you, Lexi, who have this non-celiac gluten intolerance, because that's the next place I want to do research on these. So where did they come from? Boy, was this a definitive source. They come from the finalized publication data from a failed clinical trial on a vaccine that was attempting to cure the immune system reaction in celiac disease patients. And the name of that drug is called NexVax2, NEXVAX2. So clearly version 1 failed too. I'm sorry. I'm trying so hard not to be snarky. I'm really a nice guy. I'm just saying that I had really suspicions that this wasn't going to turn out the way I believe the pharmaceutical company behind it wanted it to. And I'm more than happy to discuss why I feel that way in a very kind, gentlemanly, scientific fashion. So to answer your question thoroughly, in the publication that revealed the outcome of this trial, they found something really phenomenal. They gave 150 already well-known, well-treated, well-taken care of, asymptomatic, diagnosed celiac disease patients.
So they were following a gluten-free diet. They had no nutritional deficiencies. They were quote unquote healthy.
These were really healthy people. They were, and pardon me, but I would put myself in this category. Thank God I have great blood work and everything's looking good on paper and I feel good and things are great. And my disease is extremely well under control, especially under this quarantine. Right? So incredibly well. You don't get punked in your house under quarantine, which I know every celiac disease patient is laughing right now if they're listening to this episode. So they took these patients and they gave them 2 things, Lexi. They gave them a vaccination that contained the fragment peptides, and they won't give them fully away because they're proprietary protected by the pharmaceutical company, but fragmented peptides that would trigger a CD4 T cell response. meaning it would make celiac disease patients attack themselves.
So essentially they took the gluten and broke it down to the most simple. We hope the body is not going to attack this form, and the body still attacked it.
Yeah, this is what they did. They gave them the vaccine to hopefully turn off the attack. And then you're ready, waiting for it. You know, it's coming, drum roll. And then they fed them gluten. So, holy smokes. Yeah. And then they fed them gluten. I'm asked weekly to join these trials, just so you know. And I can tell you right now, you couldn't drag me to these trials. Do I want a cure? Of course I want a cure. Do I want to increase my risk of cancer at the moment? I would prefer not to. I have a very intense medical history. My father died of cancer at a very young age. I had heart disease and seizures and a very bad situation associated with gluten. So it is my forever enemy. And I would really prefer if we could continue our divorce. So I prefer not to be exposed to it. And I've had doctors say to me, you don't want to eat it again? And no, I don't. I don't. So what happened was, and this is a really great trial, this trial was geared towards, this is how it's so highly specific too, Lexi. It was geared towards a specific genotype carrier. So the vaccine was designed for HLA-DQ2s and actually 2.5s if you want me to be very accurate. That's 90% of celiacs. There's a DQ8. For listeners, I got the double whammy. I'm DQ2.5, DQ28, and all of those subtypes, I am positive. So lucky me. Another reason I wouldn't want to participate. So they had these patients that were just perfect for it. And the hope was that it would, what they call, re-educate the immune system towards gluten to prevent a future reaction. So then they gave these individuals gluten to test out the theory. And that's where we found out this just unbelievable, incredible piece of information. So what were the symptoms that were identified that are now considered acute? And they are in my work that has been published in November of last year, the print in May of last year, ahead of print. Acute nausea and vomiting within 2 hours.
So this is not a chronic thing. It's just you consume gluten within 2 hours, you either feel nauseous or you throw up.
Yes. Now, let me make this clear. In my journey of decades, because I'm plural, sadly, I always say the decade of diagnosis because the average is 10, 11 years. I was 20 years because I know I was born with it and got diagnosed around 20 years of age. I never had that type of symptom. So I did in my research uncover it here and there and put it into my non-classic symptoms, but it was something that would present over time when we would view patients, meaning the chronic consumption of gluten would lead to the nausea or vomiting. It wasn't something like, here's one fraction of a crouton, and then there was nausea that was severe, that was followed by vomiting. So this was really a big deal. Now, doctors have reported, because hindsight's 2020, for years, there's been a subset of celiac disease individuals that were actually saying to doctors, I'm having these acute reactions. And doctors were saying to them, that's not possible. That's got to be all in your head because it takes a period of time before there's damage to the intestinal lining and the villi, the microvilli. So clearly you've had food poisoning, you've had something else, you have dyspepsia, whatever, or perhaps even, and this is sad, but it's said, perhaps it's all in your head. Now we know for a fact that's not the case.
What's causing it? So we know that all the other issues, for the most part, are caused by damage in the intestinal tract, in the small intestine.
Yes.
Nausea and vomiting normally come from the stomach.
Yeah.
So what's causing this nausea and vomiting symptom?
You know, and this is so appropriate to the conversation we had last week. I know it sounds crazy that I'm going there, but please let me explain what the researchers identified the causes being. So one of the number one causes and problems we talked about last week on our COVID-19 show was talking about what's known as a cytokine storm. Cytokines are chemicals that are released from cells. It's really a broad spectrum term. There's so many cytokines and their nomenclature is based on where they're released. So like there could be a monocyte, which is an immature red blood cell that matures in the spleen, and it could become a macrophage and it could just hang out in the lymphatic system and engulf things in a process known as phagocytosis and defend us. What's so wild is in this case, just like the disease with cytokine storm in COVID, they identified there's a big storm of cytokines in these celiac disease patients that are DQ 2.5 positive, that were not exposed to gluten for a long period of time and in remission, and then fed gluten. They were able to measure 15 cytokines that were elevated in the response to gluten in this failed trial. And the main ones, because I said there's so many different types, so I'm just going to speak a little technical and I'll explain what it is. The main ones were a family known as interleukins. And interleukins are cell communicators, and they stimulate the immune system to start a fight, specific ones. So there's pro-inflammatory interleukins. And the ones that were stimulated are interleukin 2, interleukin 8, and interleukin 10. And those, the cool thing is those are abbreviated. IL-2, IL-8, IL-10. And the researchers were in shock because interleukin 2 and 8 literally appeared really high in the celiac patients that started showing symptoms within 2 hours. And interleukin 10, a nasty inflammatory ringleader of problems, showed up by hour 4. So this was just like a miserable cascading of events in these poor patients. And obviously this trial had to be like shut down and stopped because you're having patients get very, very sick. Interleukin 2 and interleukin 8, Lexi, they'll fire right off in the first part of in your stomach, in your antrum. You're gonna vomit. You're gonna feel extreme nausea. You could regurgitate. And it was mind-blowing for all doctors involved, where we were like, holy cow. So what was fascinating about this for me, obviously it's data and hopefully helps me help other people, et cetera, but it actually made me go back in my own life and say, wait a minute, you know, I was pretty sure I had food poisoning 3 times in 2019. And now I'm saying, no, I'm pretty sure I was exposed to gluten, and that's my new way of reacting. I have a normal immune system response. On my journey to diagnosis, I did not have a normal immune system response. I had suppressed secretory immunoglobulin IgA. We talk about that on podcasts. I failed an endomysial antibody IgA, where there's been doctors that argued that should be the only blood test. Well, I never still would have been diagnosed. And I don't even want to go there. I can't even imagine talking. That's how sick I was. So this was just like a wild thing in me, being a major researcher at the time, and will continue for the rest of my life on celiac disease, having these symptoms that must have been something that was bad in what was prepared for me. I got food poisoning because I was certain. And
So,
now I'm pretty sure I was exposed.
Whenever you either go out to restaurants or spend time with friends or family and have food there, or even buy a new processed or packaged product that you're not sure of as a celiac, let's say it says gluten-free, but it's not certified gluten-free, and then you consume that, in the 2 to 4 hours afterwards, if you're experiencing nausea or vomiting, you could have been punked and potentially ingested gluten.
Yeah, and I actually like plunked better. I think we should stick, because you're actually plunking out your lungs into the toilet. Sorry. Let's keep this highbrow. No, in all seriousness, it's such an important thing. It's such an important thing because I've had patients report these things. And of course, you know, for me, I'm always just rushing to find and identify every single symptom that could be a problem. I'm doing DNA, stool analyses. I'm referring to tropical disease medicine specialists, all that at the same time. But having said that, it's at the end of the day, most likely that these celiac disease patients were exposed to gluten. Not denying food poisoning happens. Of course it does. Doesn't happen, pardon. Of course it does. There's a whole outbreak with lettuce in my new state of California. I do think we need to be vigilant, et cetera, et cetera, et cetera. But let's be honest, you know, there's such strict regulations put on restaurants, and especially when you go to ones that are gluten literate, there's even more cleanliness I have identified. So I feel like there's just a great chance that let's be devil's advocate and say 2 out of the 3 bouts of poisoning I felt last year were probably gluten exposure, and I'm pretty sure I'm right. It's a very important thing to identify. And then you'll say, okay, well, hold on a second. So your symptoms changed. Why? Well, I finally had a normal immune system response. And that's what we identified in these celiac disease patients that were recruited for this trial. They were immunologically normal. So then they just had this voracious, unbelievable, I remember and I'm going to protect you response to the exposure to gluten, that it just makes perfect sense from a basic immune system functioning perspective. And to conclude what the doctor said on this, where they were like, wow, this cytokine production, and specifically the cytokines known as the interleukins I mentioned, and to summarize those again, IL-2, IL-8, and IL-10, those are the driving the immune system to trigger these early gastrointestinal symptoms. So I feel like it's giving us a new weapon and a new understanding of how to identify the undiagnosed portion of the population, which has always been my dream. How can I get rid of that massive amount of people that are not diagnosed in the population? Perhaps this could help, perhaps.
So would you recommend, if someone did consume an unknown food or go out to a restaurant and they feel this nausea or vomiting, should they do the proper celiac follow-up steps with their doctor?
Yes, it doesn't hurt, and at least the doctor could code it correctly. You know, in countries where there's this strong requirement for reducing out-of-pocket expenses and having the right CDC codes, it helps a lot. And a doctor could be able to say, if we could push, and I know all doctors that I'm aware of that are on this trial are pushing to have this added to the symptomatology nomenclature, you'd be able to defend that and say, this patient presented with this non-classic celiac disease symptom. We need to test them for celiac disease and go through that whole cascade of tests. I absolutely think, and I think they should do it hopefully the right way. As we talked about on an episode, I've written about it. I did an AMA on it on Reddit. You need to follow the science. You need to first check if they even have the immunoglobulins that you're measuring. That is such an important thing. Even between the dialogue, I just found that in a case. And it vexes me because I'm hired to solve this really impossible mystery. And then I show up just with these basic tools that I talk about. And sure enough, that was the reasoning, right? They're secretory immunoglobulin IgA deficient, and therefore that marker is not going to work. So now let's look at deaminated gliadin peptide IgG. And then that's boom, and we get a big old red hit, and let's do some genetics. And now let's usher towards biopsy. And sure enough, we got a positive, and we're off to the races. And if I could pepper something in about biopsy is really important. There's a lecture that was just done by a colleague of mine named Peter Green in New York. And it was done virtually, of course, during this time of everybody being sequestered in some way. And Peter was saying something that I really applauded. And I talked about Dr. Peter Green in my AMA on Reddit. Peter said, if you're doing an endoscopy and you're a doctor and you got a scope and you're looking to see if there's celiac disease as part of maybe some of these gastrointestinal complaints, and things look normal, but you suspect, celiac disease is invisible. Don't expect that you're seeing it. And he said up to 40% of cases where they had a normal appearance actually had positive biopsies. So if you're a doctor going in there, don't rely on your eyes. Sorry, throwing it out there. Get the biopsy, rely on the pathology, please.
And if you are being tested, it's important to continue consuming gluten, not follow a gluten-free diet. Otherwise, you might have a false negative. So make sure you're consuming it, even if it does cause you a little bit of discomfort, just to get the definitive answer of yes or no.
It's such a life-changing disease, and I'm still in that camp until things get better. I'm still in the camp. By the way, what do I mean by things getting better? And I discussed this on the Reddit, and I discussed this in my own writing, and Lexi and I discussed this on podcast publications. Nothing standardized in the world of laboratory analyses for the various blood markers and the upper threshold units you must hit to get an actual life-changing diagnosis of celiac disease. And I want people to really take it seriously, because what's too common in my world, and I know the listener is the N of one, but please understand that I see thousands of people. And in my world, it's very common for people to come to me and say, I gave up gluten, my symptoms went away, and now I only have it on special occasions. If I did that, that equals heart disease, cancer, brain disorders, brain disease, various neurological diseases, potentially Lou Gehrig's disease, everything I don't want, right? So I really am a big fan of the definitive diagnosis and literally running to get that diagnosis the right way. Yeah, please. So please heed my words on that.
And do you have any sort of closing notes here for the celiacs, whether they're diagnosed or they're considering, after listening to a couple of our podcasts or reading your articles, oh, maybe I do have celiac disease? What should they follow with this new information coming out?
Record this notes. Lexi and I talk about multiple times on unrelated topics to really have a food journal. I think it was probably one of the biggest things, not to put words in your mouth, Lexi, but I think it was one of the biggest things for you on your own healing path of writing a journal and associating symptoms with things and associating a lack of symptoms with subtraction, but actually recording these things. I think that's so important to do. And I think you should write it down. And in this case, If you've ever suspected celiac disease, you have an experience like this, it really is once bitten, twice shy. You should record this, date it, time it, and definitely discuss it with your physician. And in the show notes will be the full publication to this trial in the language your doctor will understand, so you could bring that to them. I'm a patient advocate for a group called celiacdisease.org. So I can also include a link to layman's terms to exactly what I'm saying, that the doctors, in their own words, identified in this trial. And hopefully putting those two pieces together and all my other writings and podcasts Lexi and I've done together will get you on a path to getting identified if you have this disease or not. And I think we probably should do a follow-up show on non-celiac gluten intolerance, because I want all of you to know I am definitely looking for these symptoms in patients that do not have celiac disease. And please let me just close on this note. You can have a cytokine storm to anything and not have an autoimmune disease. So this is a huge differential factor. You know, there's a chance Lexi could have a cytokine storm, but of course, no presence of any of the antibodies in her blood and doesn't have celiac disease. That could be driving her intolerance symptoms. Those could absolutely be the reason behind it. And this was an awesome study to give us this new information.
It's interesting because I do get quite gassy, like burping from consuming gluten. So that's
in a short period of time.
Yeah.
Wow. So
That's
it's your friends or your frenemies, interleukin 2, interleukin 8, interleukin. Look, they love you and they're trying to protect you. And they're like, let's get everybody on board to go after them. It's literally like a horde mentality of defense. And unfortunately it goes awry, and that's where the symptomatology comes. And of course, as you can imagine, being celiac, then the real big troops come in, and those CD4 T cells, and then they're going to kill your intestinal lining, and that's going to break outside the intestinal lining and go into other tissues. And we've talked about this at length, but then that's how celiac disease becomes another disease. And that's what we're all about, mitigating that.
So another podcast to come in the future on a similar topic. Keep your eyes peeled for it. Everything that Dr. Pastore mentioned today will be in the show notes. But if you have any questions or you need to reach out to clarify something, don't hesitate to reach out to Dr. Pastore. He takes the time to reply to people. You can find him on social at Dr. Robert Pastore, or visit his website, which is drrobertpastore.com. And we will see you next time on the Pastore podcast.
Thank you for listening.